Let's go ahead and get started. First off, I'd like to say thank you to everybody joining. I also see we're we're joining from all over the country. Mark from High Point, North Carolina. Thank you for joining from so far away. Hope you find this helpful. I want to talk about one of the biggest things that comes to my clinic. So I'm a hand surgeon. I specialize in the finger to the shoulder, and one of the biggest things that comes into my clinic is the numb hand. And so we'll talk all about it tonight. We'll go over the etiology, the pathology, and then answer some questions at the end. So a little bit about me. I went to undergraduate at Pennsylvania State University. We just had a big loss the other day, so I'm kind of recovering from that. I went to my medical school in Chicago, which was a great city to spend 5 years. And then I did my residency at Allegheny General Hospital in Pittsburgh, which is now the home location of this new show on HBO called The Pit. This scene on top, or the two actors here, is actually on top of the hospital where the helipad is, and you can see the great view of downtown Pittsburgh. I then did my fellowship. I did two fellowships. One of them was a traveling fellowship in orthopedic trauma, which was in Zurich, Switzerland. And then I did a hand and upper extremity fellowship in Philadelphia. If you're interested in some of the more minutia and you're interested in the research that I've done, feel free to go to pubmed.gov and search my name, and you can find more there. So the overview of the talk today, we'll talk about the symptoms of compressive neuropathy, the description of compressive neuropathy, what exactly it is, the pathology, how it starts, the different treatment options, both non-operative and operative, and then we'll also answer some questions at the end. So as I mentioned earlier, if I see about 30 or 40 patients in a given clinic day, 10 to 15 of them will come in with this main complaint. We call it the chief complaint. And the conversation usually starts something like this. Doc, my hands are numb all the time. You know what? I can't even sleep because my hands are asleep. When I drive, my hands go numb. When I use the computer, my hands go numb. My hands look different than I used to. See, right here, it looks different. It even looks different than the other side. Or my hands are constantly cramping. So generally what they say is that it feels like there's numbness and tingling going into the fingers. They don't feel like they used to. I have a hard time gripping objects. I can't feel when I'm trying to pick up something from the table. They'll say it starts at the hand or the elbow and goes into the fingers. Every now and then it'll mention of zapping. So zapping going from the elbow into the fingers, or even the hand into the fingers. They're hypersensitive to any kind of touching around the elbow or the wrist. Trouble picking up objects. For example, they can't feel the coin on the table, but they can see it and they have a hard time picking it up. They have a hard time buttoning up their shirts, and they like to dress up for church on Sunday or go to the ball game. They say that their handwriting sometimes changes because they just can't feel with the fine 2-point discrimination they used to have. And they say that when they're sleeping, they're constantly shaking their hands to wake them up from sleep. They'll also say, Doc, my hands look different than I used to. And if you look at this picture on the bottom left, I'll see if I can get the marking to work so you guys can see my screen here, or see my pointer. So they'll say, like, Doc, my hands doesn't look like it used to. It even looks different the other side. I can now see all the bones in my hand. It looks like they're wasting in between here. What's going on here, Doc? They'll even say, if you look at my thumb, this part of my thumb looks different than even the other hand, or than what it used to years ago. So what is compressive neuropathy? Compressive neuropathy is compression of a peripheral nerve that leads to a series of changes. These changes can be temporary, they can be permanent. But basically what it is, and we'll get into this in a minute, is it's a decreased signal transmission. It's either from the brain to the muscle, or it's from the skin, which is your sensation, back to the brain. These changes can be temporary or permanent, and there can be many aggravating factors which can also be temporary or permanent. Typically, though, this can be progressive. So some people ask me, are there risk factors for making me more susceptible to having this than the average bear or than my colleague down the street? And there are. Usually as we get older, this happens, and that's likely because it's progressive, more commonly in females than males. It's also exacerbated by other medical comorbidities such as diabetes, obesity, hypothyroidism, systemic inflammatory diseases such as rheumatoid arthritis or lupus, and then also can be exacerbated by pregnancy. There are repetitive activities that can cause an increase in these symptoms. For example, working at a computer desk, driving a car, or other positional activities that we'll show in a minute. So if life is like a box of chocolates, then a nerve is like an electrical wire. And if we look at the nerve on the left, or excuse me, the electrical wire on the left, easily confused, you'll have insulation. Let me get my pointer again. You'll have insulation covered by different wires on the inside. And each of these wires is transmitting a signal somewhere. For example, this one might be transmitting an electrical signal from the light switch to the living room. This one might be transmitting one to the kitchen, and this one might be transmitting one to the television or the lamp. Well, nerves are very similar. They have an outside insulation, and then each of these things are called fascicles. And these fascicles transfer to muscles, they transfer to sensory dermatomes, or they transfer to your fingers. Now, we also have in the human body, we have certain types of insulation, which is the myelin. So myelin is an insulation wrapping around the nerve. And if that gets pressed, that can then compress the nerve, which decreases the signal that gets transmitted. So if nerves are like electrical wires, they have to transmit a signal from the brain all the way through the body. That signal goes from the brain down through the neck, and that part is called your central nervous system, the brain and the spinal cord. And then it leaves the neck and goes into the periphery. It goes into either your arm, your chest, or your legs. And these nerves go in very predictable patterns that are very well documented. So in essence, a nerve could travel a very long way. It can send a signal from the brain, from the head to the neck to the shoulders, the arm, the elbow, forearm, wrist, and fingers. And anywhere along that path, if that nerve gets pressed or compressed, it can then disrupt the signal. And then that nerve also has to send the signal back for a reflex arc. If there's any compression on the way back too, that can also cause a disruption. This pressure can be constant or temporary. And it can happen in both the central or the peripheral nervous system, which today's talks about. The signal disruption can manifest as sensation numbness. Doc, my hands are numb. All of the fingers are numb. Or, Doc, I can't use my thumb like I used to, if you remember that picture from earlier. It can result in tingling or even pain. So, what are activity-related things that can cause compression? So if you think of a nerve or an electrical wire, if there's a bend in the electrical wire, that causes a disruption of the signal, or the signal might not be as strong as it once was. Well, if you look at the way that this person's typing on the keyboard, that's causing a similar kink in her nerve. In this case, it's the median nerve. Or if you look at this nice gentleman driving his car here, he's resting his elbow right where the nerve lies, so that could cause compression. But also the continuous elbow flexion could cause his nerve to travel a longer distance. If you think of the fastest way to get from point A to point B as a straight line, well, causing the nerve to go around a bend, such as the elbow, could also cause stretching or pressure of the nerve. And then also look at this gentleman, the way his hands are positioned while he's driving this car. His wrist is extended, causing his nerve to go an extra distance. So all these types of activities, whether it's driving a car, whether it is resting your elbow, whether it's sitting in a chair for a long time, the more flexion that you have in your elbow or your wrist, that can cause pressure of the nerves, which can manifest in tingling or numbness. Some other activities are sleeping. For example, when I sleep, I bend my wrist like this. Or other activities such as throwing. Throwing the ball can cause you to twist the nerve at your elbow. Or even yoga causes wrist extension compression. But they're also non-activity related. We mentioned that age, diabetes, pregnancy, or other inflammatory type arthritis can cause compression of the nerve as well. So if you think of a hose with an amount of water going through it, call it 1. If there's compression on there, then on the other side, less of a signal gets through. And in this case, it's only half. So whether the nerve is physically compressed or we're holding our body in a certain position, that can cause a disruption in the signal that goes back and forth. So what are some of the most common compressive neuropathies? The most common one that everyone's probably heard of is carpal tunnel, and that's basically pressure of the median nerve at the wrist, which we'll get to in a minute. The second is the funny bone nerve, as I like to call it, and that's the ulnar nerve that goes around your elbow. I'm sure we've all bumped our elbow and felt that zapping go into our fingers. And the third is compression of the same nerve, but in the wrist. My dad used to watch Star Trek as a kid, and he would always hold up his hand as live long and prosper. But the way I like to think of it, and if a patient, any of you listening have ever been to my office, I hold my hand like this, but actually you can see this blue line going down the finger. This delineates where the different types of nerves innervate. And so that can help us clue us in of where the nerve is being, which nerve and where it is being compressed. So the most common compressive neuropathy is the carpal tunnel syndrome. We've all heard of that. What is carpal tunnel syndrome? Carpal tunnel syndrome is pressure of the median nerve at the wrist. So if we look at, I'll try and get the laser pointer again here for you. If we look at this area right here, this is slicing the wrist in half. It's looking right through here. We have 4 bones in this depiction, but all the bones of the wrist make a little tunnel, and there's a wrapping that goes on the top. Inside of this tunnel are 9 tendons and 1 nerve. Well, the nerve is the softest thing in that tunnel. So any pressure inside of the tunnel would cause a disruption to the nerve, transmitting the signal either to the hand or back to the brain. So what can cause a disruption in that? It could be positional, like we talked about with that wrist extending earlier. It could be arthritis, which is a growing of the bone spurs or rubbing in here, causing inflammation. It could be age, where just there's thickening of the ligament. It could be diabetes causing inflammation of the tendons, or anything other space-occupying lesion. Anything that goes in there would press on the softest thing or decrease the volume of the carpal tunnel. Now that would then put pressure on the median nerve, which would manifest as numbness and tingling in the hand. And I really like this drawing because it depicts that live long and prosper that we were talking about. Everything here in purple is where, if the median nerve is compressed at the wrist, everything here in purple is where we would experience numbness and tingling. And this is on the palm side of the hand. So anything that affects the volume within the canal can cause the sensation of numbness and tingling in this region. The second most common compressive neuropathy is the cubital tunnel. What the heck is the cubital tunnel? The cubital tunnel is that funny bone nerve that wraps around your elbow. And you can all reach and touch your elbow right now. On the medial side of the elbow, you have the bump right here. Well, right behind the bump, there's a nice soft little groove, and that's where the ulnar nerve lies. So if there's pressure of the nerve in that area, or you bump it, or for example, you're resting your elbow on the chair all day, or you're resting your elbow because you're driving your car for a long time, that can manifest as pressure of the nerve, which then manifests as numbness and tingling into your small finger, and as this drawing depicts, half of your ring finger. So there are 6 structures at the elbow that can cause pressure of the nerve. And then I also see a lot of times in pitchers where if they throw the ball, this nerve can actually snap over that bump at the medial elbow. So sometimes you can even feel it on your own. If maybe it is you put your thumb on the medial part of the elbow and you bend up, and you can feel nice, soft, squishy things sometimes come up and over. That can be really problematic for people who use a screwdriver or people that throw the ball a lot, where the nerve is constantly snapping over the middle of the elbow and be very troublesome. This depiction on the bottom here also shows what we were talking about earlier of the point A to point B with a triangle. If the nerve goes nice and straight and smooth, there's no real pressure on the nerve. However, if you're consistently flexing your elbow, you're forcing this nerve to then travel a longer distance, which is in essence putting pressure on the nerve. So causes for this can be positional, which is elbow flexion can typically cause it, and which is important to remember later. It can be an activity, using a screwdriver, throwing a baseball, something like that, or the common factors such as age, diabetes, or inflammatory arthritis, or any other systemic inflammatory issues. The third most common compressive neuropathy, and I've actually seen it more here than I have in my training, is compression of the same nerve that goes around the elbow, the Guillen's canal, which is in the hand. So this is the further extension of the same ulnar nerve. And so the patient would then experience numbness and tingling in that same area, which is the small finger and half of the ring finger. Now, this also would cause pressure of this nerve here, which gives, excuse me, gives control to the muscles within the hand. So if you remember back to the first picture we showed where it looks like you can see most of the bones of the hand, that's because there's pressure of this nerve right here. So what are the most common causes of pressure of Guillaume's canal? The first is positional, hand pressure. So in Boulder, we see much more bike riding here than I did in my training in Philadelphia. So I get a lot of patients that have transient, meaning it comes and goes, pressure of this nerve, which causes numbness and tingling into the small and ring finger. They used to call this hypothenar hammer syndrome, which is during a lot of the construction, when people are using the jackhammer all the day, it would vibrate so much that would cause pressure of this nerve. But I also seen it here a couple of times with fractures of the hamate bone. Now, if you look at this x-ray on the bottom here, that nerve actually travels right here between these two bones. And so you can imagine that if you were to fall where you're skiing or snowboarding, or if you fall off a mountain bike, that you can break this bone here, and that subtly causes some inflammation and some irritation of the nerve, which can be very problematic and very troublesome. Additionally, anything space occupying in this area, such as like a cyst, can cause this kind of discomfort as well. So we've gone over some of the causes of numbness. We've gone over what some of the pathology of what happens when the nerve is pressed. And now what? What do we do? Well, if anyone on the recording has come to my clinic, you'll know the first option I always say is one option is do nothing. And I haven't read this book, but I kind of like the concept of it, how to break away from overworking, overdoing, and underliving. And to some extent, there is some truth in doing that. If you can modify your activities, you can get a more ergonomic keyboard, you can drive with a different way. Sometimes that can be enough to help get over the hump of the pressure in the nerve. But I also like to say that there's the story of the two frogs. The first frog got thrown in hot water and he jumped right out because he could feel it. But the other frog was sitting in hot water, or excuse me, sitting in lukewarm water and slowly boiled up and he didn't notice. And what I mean by that is when we're using our hands all day, every day, we don't notice subtle changes and subtle numbness and tingling that's going on within our hands. So sometimes it can take us for a very long time before we realize, hey, we have a lot of pressure on our nerves. I actually can't feel that coin on the desk. It's not something that happens overnight. It's not a light switch, unfortunately. So one option is to do nothing, activity modifications, try to adjust the keyboard, those types of things. There's also a lot of non-operative options that we can do. There are medications we can prescribe. So I mentioned that there could be inflammation in the tunnel from an inflammatory process. We can then provide non-steroidal anti-inflammatories to try to decrease that inflammation and therefore increase the volume within that space. I haven't found therapy to be too effective, but I think therapy can be very effective in helping you find ergonomic options to modify your everyday activities, the things that are specific to you that are a little different than every other patient. Bracing can be very effective for this. And in fact, that's usually the first thing I start with most of my patients. You can notice here with the wrist splint over here that I'm circling, what this does is this keeps your wrist in a neutral position so that your nerve isn't being pressed or kinked. If you remember that triangle we talked about earlier. I usually start off with patients wearing this at night. And what that does is that prevents you from putting your hand in a flexion or an extension position and gives your wrist about 6 to 8 hours chance to rest and recover and overnight. This is an elbow, and this is called a heel bow pad. And what this does is this tries to keep your elbow a little straighter than it normally would to keep the tension off the nerve, but also a little extra padding so that when you do rest your elbow on either your armrest in the car or on your desk, that there's less pressure directly on the nerve. There's a little more support there. There are certain things you might read about, such as steroid injections or platelet-rich plasma. I have had some success with steroid injections in the carpal tunnel, much more so than the cubital tunnel. And I've also seen some success with platelet-rich plasma, although not as effective as steroids. But this is another non-invasive option that would direct a high-potency anti-inflammatory into these areas to try to calm down any inflammation that's there. But at the end of the day, my role as a physician is to be a detective. And if you remember where we talked about earlier, the signals come from your brain, down your neck, and down your arm. I need to figure out exactly where it is so that any treatment options we discuss, we know are going to help the patient-specific factors that are coming to my office. So I have a team that helps me. As we mentioned earlier, the electrical signal travels a long way from the brain all the way to the hands. It goes through the head, the neck, the shoulders, the arm, the elbow, the forearm, the wrist, and the fingers. And I'm sure many of the listeners here have many friends who even have had experience with neck pathology, or the doc said it's radiating down the neck, or have even had neck surgery. And so our job is to find out exactly where it's pressed so that the treatment options we offer you will provide a benefit for you. So I typically start off with x-rays. That'll help me know if there's any type of fracture, any space occupying mass that could be pressing the nerve. And I'll also refer you to one of my colleagues, Dr. Katrina Slater or Dr. Ilya Golnikov, for an EMG. This is typically the gold standard for diagnosing compressive neuropathy in the extremity. What they'll do is they'll take electrical signals here in the hand, and they kind of test how the nerves are working, so they can measure how fast the signal is being transmitted across the nerve, how strong the signal is being transmitted. If I started at point A and point B, if you think of that tube that I showed you earlier. They'll also do a dynamic ultrasound. So they'll ultrasound your whole arm and find out if there's anything pressing on the nerve, or if the nerve looks bigger or smaller than it should, and where it's exactly bottlenecked. So they can be very helpful in helping us diagnose what's going on. For example, here's a select cut from an ultrasound showing the flexor tendons in the space and the median nerve here. And so you can see if your nerve is supposed to be a little tube, that this one's nice and squished and really flat. So this patient has pretty severe carpal tunnel syndrome. So if the non-operative treatment options don't work, for example, bracing overnight, the oral medications, maybe even an injection into the carpal tunnel, or bracing at the cubital tunnel, are there surgical options that can work for this? There absolutely are, and I try to do this as a last resort. For the carpal tunnel, there's two main surgical options. The first is what we call an open carpal tunnel release. And so this gray representation here is the transverse carpal ligament covering the nerve. And so what we do is we make an incision and we open up the transverse carpal ligament. And so that removes the pressure on the nerve. And you can see, if you look at this nerve here, there's a little hourglass depiction of the pressure that has been chronically on the nerve. The open carpal tunnel release has an incision in the palm. And so sometimes between the two different surgical options, there's an open and an endoscopic. I prefer the endoscopic version because there's less pressure. For example, when you're going to get up from a seated position, you're pressing on the palm, or you're grabbing objects, that puts a lot of pressure in the palm. So this can be a little bit more of a painful recovery, but again, not too long, usually 2 to 3 weeks, maybe even a month. The next option would be an endoscopic carpal tunnel syndrome, or an endoscopic carpal tunnel release. And that's where I make a small incision just proximal to the release, or proximal to the wrist. And I take a camera and a knife, and I make a little tunnel into your hand and a little tunnel into your forearm. And I look directly at the transverse carpal ligament, and I can cut it with a knife just using the camera. This comes with a very small incision, and typically patients have less pain in the palm when they're getting up and doing their activities, when they're driving their car, when they're doing push-ups, when they're doing things like that. Both techniques have been shown to have very good results when done competently and effectively, and have had a complete release of the ligament. So what about the cubital tunnel release, where there's pressure of the nerve at the elbow causing sensation or numbness and tingling going into the elbow? Well, there are also two different kinds of procedures for this based off what the actual problem is. So if the nerve is just pressed at the elbow, then we can do what we call an in situ release. That's where we release it where it is. And we release those 6 structures that I talked about earlier. And that takes all the pressure off of the nerve. Now, if that doesn't work, or for example, in the baseball players, the pitchers that are out there, where they can feel that the nerve is snapping across the elbow, there's another procedure for that as well. And what that would be is that I would release it exactly where it is, and then I would also move it to the front of that bump that we looked at earlier on our elbows. And what that does is that gets rid of the snapping of the nerve going across the elbow. So overall, numbness in the hand is a very common problem. It's probably 25% of the patients that come to my clinic. it can be easily confused with other pathology. We talked about the nerve coming from the head, down the neck, and into the arm. The nerve can get pressed anywhere along that path. And then when it does get pressed, our job is to figure out where and how it's getting pressed and how we can help you. The important part of understanding where it is the history, what the patient's telling you, a good physical exam, and then finding specific testing to help me find out where that nerve is being pressed. Overall, it's an individualized approach, and there are numerous surgical and non-surgical options to help patients with the numb hand. And overall, it has a very, very big impact on the patient's life, quality of life, and their ability to go back to their activities. So thank you, everyone, for joining in, especially Mark from High Point. I can't see where anyone else is from, but all over the country, apparently. I'm happy to answer any questions. Sally, I don't know if there are any questions from the group, but I tried to leave some time at the end here.
Yes, so far we have a question here from Morag, and they say they have numbness in both zones of the hand.
Yeah, that's a very common complaint. And most of the time, most patients don't think of it as like, oh, which exact finger and where on the front or the back of my hand is it numb? Usually it's just, man, this is annoying. This numb hand wakes me up all the time. Where is it coming from? I would say from my experience, it's more common than not, it's a carpal tunnel syndrome, but it also can be cubital tunnel as well. And that's where the diagnostic testing, such as the EMG, the ultrasound, will really give us some data around exactly what is going on. And then we can have a patient-specific dialogue of exactly what's going on and how to proceed moving forward.
Right. What is a foosh is another question.
Foosh, fall on an outstretched hand. Very common complaint for hand surgeons.
All right. And how long can steroid injections last?
Good question. You know, I think a lot of things, and I try to stress this a lot, is everything is individualized. So, for example, is it that you're a truck driver and you're spending 14 hours a day driving a truck and you're constantly in that position? Or is it that you just maybe had a little carpal tunnel syndrome that acted up when you're pregnant? I think all of the different factors that are specific to you can have a big impact of how long something can or cannot work. Some of the literature shows that they can work in anywhere from 40 to 70%. Well, you're like, doc, what the heck? That's a huge range. And that's because the patient specific factors are so important with that. I've been able to give some injections and the patients do great and they never come back with any other complaints. And other patients, they get an injection in that area and they have problems a week later. It's really hard for me to have great predictors on if the injection will work specifically for you. But a lot of those other factors can play a lot of roles too.
Great. How does leaving that structure around the median nerve cut affect your hand post-surgery?
So I assume what you're referring to is in this picture. Let's see. I hope you can still see my screen. In this picture, when we cut the transverse carpal ligament, what happens to the hand essentially is I think what you're asking. And the studies show what happens is your wrist just kind of opens up a little bit. There's been no significance from it. They think that the transverse carpal ligament is a remnant from if you believe in evolution, from evolution a long time ago, and that it's not necessary. So overall, we haven't found any deleterious effects of releasing the transverse carpal ligament for carpal tunnel surgery.
Jan is writing in from Costa Rica, and she had an EMG with Dr. Agolnikoff, and he said there were no issues, but the wrist area is still numb and tingling after shoulder surgery. What do you think?
So it's interesting that we're global. We're global now with Costa Rica and multiple countries. This is great. So I think this is the point of where having all these dynamic tests can be very helpful. So Dr. Golnikov is great, and I rely on him very dearly for his EMGs and his ultrasound. And it sounds like in your case, it's very specific of this maybe happened after a shoulder surgery. in which case this is our job to try and figure out if it's coming from your neck or somewhere in the arm or hand. And this is something that does happen a lot, is that after a different type of surgery, it can put pressure on the nerves either in the neck or somewhere in the arm. So without knowing the specifics of your exact case and the specifics of what's going on, or even seeing the results of the EMG or talking about it with Dr. Golnikov, it sounds like this might be coming from your neck or something like that, which is a very common cause.
Great. I had numbness, but a normal EMG, and now have a trigger thumb. I've had steroid, but without relief. Is it related or something different?
Yeah, this can be very confusing too. And sometimes when we get to a certain point, it's like we have all these things happening at once and they all seem interconnected. We don't have a great scientific explanation of carpal tunnel and trigger finger being linked. However, in my experience, there do happen occasionally together. So it sounds like there are two separate things in your case, but I would have to examine you and try and figure out for sure.
Okay. How long does it take after carpal tunnel surgery to regain feeling?
This is a very good question, and this is why I rely on the EMG as well. The EMG can help us quantify the level of compression that is on your nerve. So, for example, we typically put it into three different categories: mild, moderate, or severe. Mild compression typically has a great prognosis for almost complete recovery to your sensation of when you were younger. Moderate is a little more subjective and a little more vague of how much relief you will get. So I typically tell patients the goal of surgery is twofold. The first goal is to take the pressure off of the nerve. The nerve is no longer kinked. The second goal of the surgery is to then allow your body to heal. So, for example, if we look at this picture here with the little what we call an hourglass deformity of the nerve, it can take your body a long time to heal that. Therefore, the number one goal is to stop your hand from continuing to get more numb, but then give your body a chance to heal it. And if you remember back to biology class in 7th or 8th grade, where you saw the single red blood cells floating through the tube, that's the healing potential of nerves. They have microvascular blood supply. And so with a limited blood supply, it has limited healing potential. That's why it's so important to get a hold of this and manage this as early as possible. The severe category, I have very low hopes for the nerve to get much better, but I have good hopes that interventions would prevent it from getting worse. I also find that even in the moderate and severe categories, that by carpal tunnel release, you do get resolution of the nighttime constant numbness and tingling, but you might not get an increase in your 2-point dexterity. The 2-point dexterity is what you use to pick up pennies on the table, or what you use to feel subtle, like braille, for example, things like that, to feel subtleties in different textures. But I do think that you have a very good chance of getting relief from your nighttime numbness, the things that are keeping you up from sleeping, etc. And that can be a big improvement in your quality of life.
Right. Greg would like to know, does arthritis in the thumb or fingers lead to numbness?
Indirectly, I would say no, Greg. But if you think there are so many different joints in the fingers and the hands, for example, each finger has a joint here, here, and here. Typical arthritis, which I believe is what you're referring to, is osteoarthritis, which is wearing out of those joints. There's also inflammatory arthritises, and those can be an autoimmune disease or they can be just general inflammation, which can lead to numbness and tingling in the carpal tunnel. So I know that there are generic terms we use, such as arthritis or things like that, but it's really important to address a patient specifically on what their particular issues are. Do they have a rheumatoid arthritis? Do they have an inflammatory arthritis of a different kind? Or is it osteoarthritis? And those will help us figure out where exactly the pressure is, what is causing it, and specifically what nerves are being pressed. Also, maybe not in the finger, Greg, is not what you're referring to, but arthritis in the neck is a very common way to get numbness and tingling in the hand. And I know what you're thinking. What the heck? How is my neck connected to my finger? Well, the nerves come out of little tubes, little holes in your neck. And if you get arthritis, that makes that little hole smaller. And that puts pressure on the nerve right at the neck where it's coming out of your neck. Then what that does too, if we look at our other picture earlier, I'm going to go back for you. If we think of this picture here, Greg, and you have 100% of the water coming out here, and you have a little pressure in your neck, and now you have 50% coming out. Well, you can imagine that if you have any pressure at your wrist, now you only have 20% coming out. So that's what's called a double crush. That's where somebody has pressure in their neck and in their wrist or somewhere else in their arm. And that can be particularly problematic. That's where I work very closely with my colleagues in the neurosurgery or the spine field to make sure we're adequately decompressing both their neck and even in their hand.
All right. Rachel says when sleeping on her side, she has numbness both in the hand on the bottom and also the hand on the top. Does this make sense?
It can. And it can be multiple different things. It can be something like we just talked about with Greg, where it's coming from the neck. And when your neck is in a particular position, you're either stretching the nerves coming out of your neck, or on this side, it would be compressing the nerves coming out of the neck. It can also be very positional. For example, I think I showed earlier, I don't know if you can see my video. When I sleep, I kind of sleep like this, and that's putting a kink in my hands. So it could be a combination of both. I also sleep like this, and you can't really see, but my elbows flexed. So I could be doing 3 different things that are causing pressure of the nerves that are then causing numbness in the hand. Without getting too specific, because I would need to examine you and probably get some additional testing, I think it's likely that it could be one of those areas.
Right. And Hillary says that sometimes she has so much compression that her shoulder, arm, and hand go numb.
That's certainly possible. That's where I would definitely recommend you see somebody to try and figure out where this is coming from. And again, if we think of the frog analogy earlier, sometimes it's very acute. I fell off a bridge or something, and now I have numbness down my arm. That's something we know. But a lot of times, if you're just in the water as the temperature is slowly increasing, you don't notice these changes day to day. So that's where you might want to see Dr. Agolnikov, Dr. Harper, or myself, or Dr. College, or Dr. Master, somebody who specializes in these kind of peripheral compressions and can help you figure out where it's coming from, because it can be very troublesome and problematic.
John broke his wrist about 11 years ago, and he didn't have any problems until recently. Is that normal to see that kind of effect so many years later?
So when somebody breaks their wrist, I always ask them, do you have any numbness and tingling in your fingers? The reason is, if you, let's see, I'm going to try and pull up. If you think of somebody breaking their wrist, that would definitely, if you think of somebody breaking their wrist, that would definitely put some pressure inside of this tunnel, which would then put pressure on the median nerve. Now, also too, when scar tissue, we talked about anything that would affect the volume of the canal. If slowly, subtly, scar tissue builds up on either the tendons or inside of the canal here, that can definitely make the volume of the canal small, which would then put pressure on the nerve. So absolutely, that is a common thing. And John, you mentioned that this happened 11 years ago. One of the biggest factors, unfortunately, is as we mature, as we age, we're more likely. So the fact that you have probably some scar tissue in there, maybe the volume's a little smaller, and we've now gotten a little older, those combination of things, it doesn't take much to press on the smallest thing inside that canal.
And Rachel wants to know what can be done for bikers with hand numbness.
Yeah, that's why I put this in the talk here, Rachel. I did my training in Philadelphia, and let me tell you, they do not ride bikes nearly as much as they do here in Colorado. Not to mention, you got to be safe when you're driving with all these bikers around. So what that is when you're pressing on the bike handle here, that's putting pressure on this nerve, which is causing numbness and tingling into this. What you can do is you can put a little extra padding on that area. So biker gloves that have a significant extra padding, that's why they're made that way. The extra padding right in this area on this side of the hand. You can also try to hold the bike handles in a different position. So instead of holding the handle of the bike down like this, some people have the curves, which then can put your hand in a more ergonomic position. And then you can also do things like rest your forearm on the handlebars, like I've seen in some of the Tour de France riders. So there's lots of things that maybe a therapist, like somebody like Sally, could really help you do. Or even if you go to your local bike store, they might have tons of different gloves, because I bet you're not the only person experiencing this as well.
Yes, true. We can even custom people's gloves. And there's two people who want to know about a trigger thumb, and is it related at all?
So trigger thumb, and I'm glad you bring this up because I think in the beginning I mentioned I'm going to try to do a couple of talks every month or so. And we can talk about trigger thumb another time. But basically, trigger thumb is if you see my hand, when I wiggle my fingers here, you can see these little strings moving right in my palm here. And you could even look at your palm and see the strings moving. Well, when those strings get in here, they go down to the tips of your finger. So the muscles that move your finger are actually in your forearm here. And they go by these little strings, and when they pull, that causes my finger to go all the way down. That causes this finger to go down. Now, if you think of like a fishing rod or you think of pants with a belt loop, in order to get a mechanical advantage, and so that the string doesn't take just the shortest distance from here to here, it goes through all these little loops here to keep it mechanical advantage. And so what can happen is as we age, if we're diabetic, things like that, that can make us get more likely and predisposed to getting a bump on that string. And as you can imagine, if you had a bump on your belt loop or you had a bump on a fishing line, as it's going in and out of those tunnels or in and out of the loops on the fishing rod or in and out of the belt loops, it can click and pop and snap as it's going through. And that's what's happening with trigger thumb or trigger finger. So generally, that is not necessarily related to a carpal tunnel, although if you think of an inflammatory type picture where you get inflammation of the tendons, either in your carpal tunnel, that can also cause inflammation of the tendons near your finger and cause a similar type picture. So they're more indirectly related than directly related, but they're not related.
If hand numbness is coming from my neck, is it hand surgery or neck surgery?
Good question. I think both of us are well trained in diagnosing where it's coming from and working up what we call a workup to find out where it is, involving an EMG, X-rays, or MRIs, things like that. But typically, if somebody requires surgery because the pressures at the neck, that would be an orthopedic spine surgeon or a neurosurgeon. But Dr. Harper, who's one of my partners here, he specializes in orthopedic spine. He actually sits in this chair right behind me. And we talk all day long. We share patients back and forth because they have complaints, and we're detectives trying to figure out where it's coming from. So I would say if you could get in one of the offices, whatever is easier for you to get into, either a hand surgeon or a spine surgeon, we will usually be able to detect where it's coming from and then refer you to the right person to help you take care of it.
Can a daily anti-inflammatory like meloxicam help?
I generally like to try anti-inflammatories. I think it's a low risk, high reward. I generally do not want to put patients on a medication for the rest of their life, and I generally don't want to cause any upset stomachs or things like that. So after taking a thorough history, a physical, discussing with the patients all the different treatment options that we kind of talked about earlier, I will throw out an option prior to a surgical intervention. Let's try some wrist bracing. I think it's okay to try a non-steroidal anti-inflammatory as long as you don't have stomach problems or kidney problems, something that would prevent you from taking the anti-inflammatory. I think it's worth trying multiple things in order to avoid a surgery in the first place.
My small finger and part of my palm often fall asleep when I'm sleeping and wakes me up, as you mentioned. Can this also be a vascular and not a nerve issue, or are they a similar thing?
It's much more rare to be a vascular issue. Typically, if it's vascular issue, it's up at the neck level. It's like a brachial plexus type pressure. However, it sounds like you do something like I do, and that's where you sleep with maybe your elbows flexed, and that would cause numbness in your hands or fingers. So it might be worth trying the heel bow pad. There are also numerous other ways to detect if it's coming from a vascular issue or if it's coming from a peripheral nerve issue.
How often does carpal tunnel reoccur after surgery, and how can this be avoided?
This is a hot topic in the hand surgery minutia world. There typically it is very, very rare for carpal tunnel to recur. There are a couple of reasons why it would recur. One, if the transverse carpal ligament was not completely released the first time around. And I'll show you what I mean by that on the picture here. So if this is the transverse carpal ligament and you release 99% of it, but one little band is intact, that little band is still causing pressure. And it's actually even worse than not releasing the whole thing at all. It's actually worse to leave one little band than to not cut the whole thing. And that's because it's almost like a cheese grate wire that's putting a ton of pressure very focally on the nerve. So the most common reason that carpal tunnel would recur is an incomplete release. The second most common reason would be you have something new that happened. For example, you have a big cyst that occurred in that area. Maybe you fell and broke your wrist and that's causing a ton of tightness. However, if the job is done correctly, the whole transverse carpal ligament is released, including a lot of the fascia going into the forearm, then it's very rare for it to occur, less than 1%. I think overall studies show that about 1 to 2% of the time it can recur. And usually it's over a course of many years with an incomplete release. So things that you could
Is it
do,
cold? Oh, sorry.
things that you could do, and it's honestly out of your control. It's if the surgeon did a complete release or not would be the most common reason.
Sorry about that. Is a cold hand in the indication of neuropathy?
The cold hand is a whole nother discussion for a whole nother topic and can be many different diseases. Usually that can be like a vascular reason, such as Raynaud's phenomenon, where your fingers go white, Brugger's phenomenon. But it could also have the sensation from compressive neuropathy causing your hand to feel cold. And this is where it's interesting because if your brain isn't used to feeling certain things, for example, if a lot of times if patients break their wrist, they might have pain in their elbow. And that's because when a patient or when you're experiencing something inside of your body, your brain isn't used to it and your brain can get confused. So sometimes the way that the words that people use to describe what they're feeling can be a little different because the brain might interpret things differently. But typically, a cold hand is a vascular problem, Raynaud's phenomenon, Brugger's, etc.
Is there someone at Boulder Center who focuses on legs and feet? I have numbness resulting from a knee replacement last March.
Yeah, there's many physicians here that focus on that. After a knee replacement, I'd probably recommend you see one of the adult reconstruction specialists and have them kind of go over what happened, what was done, and see what they think first. And usually we're all pretty good about finding or at least helping get the process going of what is going on and then get you to the right person when the time comes across.
Great. And Jan back from Costa Rica says, is there any harm in taking 300 milligrams of gabapentin? I've had this since last October of 23 and it helps. It takes away the tingling and numbness. I want to just keep taking it until I can come back to Costa Rica to get an appointment. Would that be okay?
Without getting into specifics and knowing your medical history, all medications do have side effects and can have complications with them. So I don't want to get too specific into your case, but I would say if you're taking gabapentin under the direction of a physician who knows your medical history and knows where you're working with, I think that would be an okay thing to do. But again, I'm not your direct physician and I'm not familiar with your specific case, so I don't want to give you recommendations on a prescription medication. I wish I could help you a little more. I'm sorry.
Great. And I think that's the last of our questions. But if people do have questions, everybody has my email. So I'm Sally at Boulder Center. And I was the one writing back and forth to you. So if you have questions later, feel free to reach out to me and I can get talk to Dr. Hammarstedt. And so thank you.
Thank you everyone for joining, especially across the globe. This was really cool.